Top Med Talk.
Hi, it's Monty Mython here, Editor-in-Chief of Top Med Talk. Well, these are extraordinary times. Despite all the challenges we face, we will continue to deliver free, open access medical education for as long as we can manage it, as well as our new regular updates on COVID-19, the global pandemic of coronavirus. Reporting from the front line, we'll be concentrating on enhanced surgical recovery. Why have we made that decision? Well, with an unprecedented pressure on resources, many institutions have decided to accelerate their widespread adoption of enhanced recovery. And why? Well, it's never been a more important time to reduce complications, readmissions, avoidable ITU bed occupancy, and to get our patients home fitter and faster after major surgery. As somebody who's about to get back into the trenches in critical care, to all my surgical, anaesthesia and perioperative care practitioners, thank you for making this a priority. A big shout out to our sponsors, in particular Edwards Life Sciences, who have very generously agreed to continue to support this resource, that's Top Med Talk, at a time of global need. We're all in this together. We will get through it. It's going to be fine.
Our next speaker is also truly inspirational, has been part of the Prehab family since the day we started. Daniel Santamina is an assistant professor at the University of Toronto, is a scientist at the Princess Margaret Cancer Centre, has been developing and implementing prehab and rehab programs for patients with cancer. However, unfortunately, he is only 6'4", unlike Stefan, 6'11". Daniel.
Okay, well, that is a tall act to follow, and the jokes only get worse. I'm sorry. But I have the humble pleasure of talking about professional disciplines, and specifically maybe with respect to exercise as it pertains to delivering prehabilitation, but possibly and also a dubious distinction of having to present on other professions who are involved. So I'm going to do my best not to offend anyone. And I think from teaching a graduate course in interprofessional collaboration and practice, I think it's safe to say that perhaps at one point in time, everyone has perhaps butted heads with a colleague in a similar or complementary, as we may call it, profession. Yes, I would say that on occasion in the development of our cancer rehab and exercise programming, there were some differences of opinion, and perhaps there were some butting of heads. But what I've found within the context of prehabilitation and its novelty, there's been the opportunity to learn from each other in ways that are somewhat more complementary. So I'm glad this made you go, ah. So we're starting off on a good foot. Okay, so who is in the prehab program? And at the end of the day, it really does depend. There are many caveats that have been presented to you over the last day and a half or so about how to deliver different parts of a program and what comprises of a prehabilitation program. And in general, what we've seen quite often is that exercise and nutrition and psychological management are our core components, but perhaps sleep is very important, et cetera, et cetera. And there are actually a lot of different intervention elements that we could consider. But it depends on really what you have available to you. Who is a part of your team? Who is a believer, as Stefan just said? You may not necessarily have a collaborator who is a believer at the start, so you have to start with who you have. At the end of the day, we are patient-centered. At least we try our best to be. And it depends on the types of treatment that patient will undergo, the phases of treatment that they'll undergo, as well as a number of other factors that the patient will present with when they arrive at the prehab clinic. So the answer to the question about what comprises of prehabilitation and who would deliver a prehabilitation program really does depend on a number of factors. We presented this as a bit of a model towards breast cancer prehabilitation, and generally speaking, what we think of prehabilitation in some ways often is delivering exercise that is both targeted to the muscles that are likely, or the tissues that are likely to be affected by the surgery or the type of treatment you may undergo, general conditioning of the musculoskeletal and aerobic systems, high-intensity interval training has been a common element of delivering that. We also have discussed a lot about nutritional optimization, not necessarily just protein, as Chelsea has said earlier on, but making sure that our diet is well suited to overall health, stress reduction, and behavior change to support a variety of the other modalities of prehabilitation, smoking cessation. And obviously there is medical optimization. Medical optimization in terms of management of medication, anemia, and a number of other factors that we have to consider. I think what I can spend my most time focusing on are the behavioral prehab interventions. So I'll start off with exercise. So as a kinesiologist and exercise physiologist, this is probably the space where I'm most comfortable with. But I think it's important to perhaps start off with a bit of a distinction and describe that exercise is movement, but not all movement is exercise. And perhaps there is some conflation of the two terms, exercise and physical activity. Physical activity, very specifically, is any bodily movement produced by skeletal muscles that results in energy expenditure. What we just did now was some physical activity, and depending on how vigorously you were dancing, maybe that got into the exercise range. And if you were to do it repeatedly, and with the purpose of improving your physical fitness, we then move into the realm of what we would consider exercise, a subset of physical activity that is planned, structured, and repetitive, and has as a final or intermediate objective the improvement or maintenance of physical fitness. I'd like to consider that exercise both comprises of conditioning-based exercises, those types of movement patterns that focus on global wellness and physical fitness, as well as exercises that are impairment-based, that focus on local regional dysfunction and disability. And when I'm considering prehabilitation, I'm often considering these as the interventional ingredients from an exercise standpoint. We always encourage a physically active lifestyle. That is something that is inherently good for our health, and the data are convincing. But in a very short time frame, such as the few weeks before surgery, we need an exercise dose that is both targeted to the type of treatment that the patient is undergoing and is sufficient to change physiological parameters that are related to the outcomes associated with surgery that we've seen in the literature. In a cancer rehabilitation setting, as we've developed programming, we developed this schematic to help us wrap our heads around what we deliver as an interprofessional team. And there are a few elements of this particular slide that I want to highlight. In that, on one side, we may consider some things cancer rehabilitation, where the primary focus of rehab is to restore function and ability. The primary clinicians, maybe the physician, the physiotherapist, occupational therapist, or nurse, but I really want to underscore the term primary, because this is a true gradient from high impairment to low impairment, where there is overlap and complementarity in the delivery of these services by different healthcare professionals. And on our team, our kinesiologists and exercise physiologists work in some of these spaces supported by the aforementioned clinicians, but they may not necessarily always be the expert in that particular area. There really is a harmonious relationship between these two groups. And I think we've achieved this, but it didn't happen on day one. On the other end of the scale, we have cancer exercise, where again, the primary focus is to optimize performance and health. Maybe the primary clinician is the kinesiologist or exercise physiologist with a scope to look at conditioning-based exercises. This is not to say that the physiotherapist does not prescribe conditioning-based exercises. This is not to say that the exercise physiologist does not help or support the physiotherapist in delivering rehabilitative exercises. There is complementarity in these two roles, where in many cases they support each other in optimizing the function of the patient. We also have to remember that after many of these surgeries, there are rehabilitative programs that are within the wheelhouse of certain professions that are going to be skilled and trained in that area. And so if we can introduce some of these rehab protocols in the preoperative space, we'd like to think that their postoperative protocol adherence is much better. We need these two teams to work together. This is a bit of a tricky slide to digest, so I apologize for how it may appear here. But in terms of who is the most qualified or who should be delivering exercise, from a physical activity standpoint, we'd like to think that everybody in this room has a role at some point in time in describing the fact that exercise or physical activity, being more active than sitting, is good for your health. So I'd like not to think that this is a scope-specific type of recommendation. Physical activity is healthy and is something that can be supported by everyone. And we've seen routinely 150 minutes of moderate to vigorous physical activity as a general guideline. When we're thinking about conditioning-based exercise for clinical populations, at least in some settings, our setting in Canada, in Australia, in the US, certain terms resonate with a particular scope of practice related to exercise for clinical populations. The kinesiologist or the exercise physiologist are common terms in that particular space. And for those who are not necessarily all that familiar with working with these professionals, they often have a 4-year undergraduate degree, often graduate degrees in exercise sciences that have specific training, certification, and licensure to work with those who have clinical needs. Now, there has been a lot of discussion about the scalability of prehabilitation and whether or not personal trainers in various settings should be the deliverers of prehabilitation under the supervision of exercise physiologists or those who have some training. And I think this is absolutely a possibility. And I appreciate that a caveat to everything I'm saying here is that there are many regional differences in how certifications and licenses are distributed, the scopes of practice, and so on. So these are some examples of what you might see, but the titles may differ between region and the training may differ between region. From an impairment-based exercise standpoint, it's typically the physiatrist. And I'm aware that the physiatrist is a term that's not necessarily all that well known around the world. It's certainly in our cancer rehab and exercise program. He is our medical director. He is our medical lead for all things rehab and exercise. And for those who are not familiar with the physiatrist, they are physical medicine doctors. And they really do provide an expert level of medical advice related to the description of exercise and rehabilitation. In our program, physiotherapy assistant kinesiologists as well can support the physiatrist and physiotherapist to deliver the rehabilitative regimens that they prescribe. And these, again, are delivered in combination. And I just want to highlight again, there are many exceptions. We have occupational therapists who deliver fantastic physical activity and exercise programs in our team. And really, it really comes down to your local/regional training, qualification, certification experience, and perhaps a supervision as well. If I move on to nutrition and diet, suppose I'll pose a question to the audience first. If looking at these 4 bullets, is this a dietitian or a nutritionist? And I'll give you just a moment to work through those. And so, perhaps without putting anybody on the spot, it's a bit of a trick question because it entirely depends, and at least in one province in Canada, this is registered dietitians and registered nutritionists. And in this particular setting, both of those titles are protected. And I think one thing to highlight within this talk is that registration or the protection of a public by a college that oversees the quality of care is essential to a lot of the delivery of the prehabilitation programs that we have. But it is not universally the case. And I think you have to look again at your local setting to figure out how supervision and how connection to the programs and overseeing bodies can support those that don't necessarily have a regulated body. It's not universal. Again, in our country, in Canada, what we find is that nutritionists and dietitians can be used interchangeably in some provinces. Some of them are very protected versus the other. For example, in Ontario, a registered dietitian is the person you go to for food consultation, and a nutritionist is non-regulated and sometimes not necessarily considered as credible. There are these challenges, but even within our country, there are distinctions in terms of what term to use. In the US, it's registered dietitian nutritionist. And I'm not sure what it is around the world. These are 2 terms that pop up as when I go to either the UK or Australia, etc. But different regions within countries sometimes have regulation in the setting slightly different. So I would recommend within this particular space to consider how the dietary consultant is prescribing and supporting an intervention and whether or not they're regulated and what that means in your particular setting. One of the interesting parts about our program is that although we try to provide very healthy food and food that speaks to the needs of a person with cancer, a chef can make that food taste very good, look very good, and we're very fortunate to have Jeremy who makes sure that all of the stuff that the dietitian puts together, because it's so healthy, and we know that very healthy food doesn't always taste that fantastic. So Jeremy tries to present it and add flavors that align with the dietary principles that our dietitian Stephanie provides. So I think that when you think about your team, it's okay to expand. It's okay to think novelly. And it's okay to think, what would make the patient want this more? So on our team, we've been very fortunate to have it. I'd recommend that you check out the ELLICSR Kitchen on YouTube. There are hundreds of recipes that make healthy food for people with cancer taste and look good. And this is two fantastic people who make it reasonably entertaining as well. Psychological and behavioral prehabilitation. I had a nice chat with Dr. Grimmett earlier about how to present this, and it's a tricky one. In talking a little bit about the distinction between psychological prehabilitation and behavioral prehabilitation, it supposes that they are distinct factors, and I think, again, to some extent, it depends. So can we distinguish between the two? Well, in talking to my psychologist colleagues in Toronto, changing behavior is a fundamental element of a psychologist's role in managing a number of psychopathologies. Making sure that their thought patterns and how they interact with their colleagues, friends, family, and the world around them requires strategies like cognitive behavioral therapy, which inherently includes behavior change. And to some extent, we have another slant on this field that looks at how do we support behavior changes in a prehabilitative context. So there's a psychological distress or psychopathology element, and then there's the behavior change element, and sometimes they overlap quite a bit. And in fact, very often the same clinician can support both. It's a little bit tricky. Again, it will have some regional context, but I think cognitive behavioral change or cognitive behavioral therapy is probably a great example in terms of looking at how the distress and the psychopathology support from a clinician can be complemented or integrated with behavior change strategies. This is a fairly dense slide, so my apologies, but when we're thinking about who delivers prehab in this particular context, from a behavior change standpoint, it's my opinion, and I think this is shared by a number of my colleagues, that all practitioners can help support behavior change, and this really speaks to making every encounter count. If the nurse is reinforcing exercise and smoking cessation, and the kinesiologist is reinforcing dietary patterns and stress management, and the surgeon is saying you should do all three, and the anesthetist is saying doing all three, we all have an opportunity to endorse the behaviors of our colleagues, and I would suggest that there's great value in learning behavior change techniques that can be learned in a workshop, maybe not becoming an expert in it, but there are some tactics that you can use about changing your language and changing your approach to patients that can support helping some of these behaviors be adapted into your lifestyle. When it comes to relaxation and stress management, which is a common element of prehabilitation programming, it really depends on what you're trying to deliver. If it's breathing exercises or perhaps yoga or Tai Chi, some of these do require certification or additional training. Yoga and Tai Chi are often used as relaxation and stress management strategies as well as physical modalities of prehabilitation, or at least in other settings. Certainly not everyone is a yoga expert or Tai Chi expert, but depending on your setting, if you have access to someone with those skill sets, they may be important to have. Psychotherapy, again, this is in the presence of those with more significant issues related to their mental health. In this particular scenario, I think it's worthwhile really consulting with your psychologist, psychotherapist, and psychiatrist colleagues. These are who deliver our programs at the Princess Margaret, and they are the ones who deliver also the stress management and relaxation program. So again, there are opportunity for those to work maybe within a few elements of the psychological/behavior change area. If there's a significant need for pharmacotherapy when it comes to psychological health or well-being, then certainly physicians are involved, and maybe primarily the psychiatrist. We won't spend too much time in terms of cessation of adverse health behaviors. We had great talks earlier about smoking cessation and alcohol as well. But in terms of delivering prehabilitation and consideration for the cessation of unhealthy behaviors, this again is a team approach. It could be the physician, often in a smoking cessation program, consultation or at least referral to a pharmacist for smoking cessation support, psychology, psychotherapy, social worker, and really it's the entire team that can reinforce some of these behaviors. However, in some circumstances, depending on the nature of the adverse health behavior, it may be a specialist in that field. To wrap up, I just wanted to talk a little bit about perhaps the collaborative approach to working together in a fairly complex period of time for the patient. You've seen these models before. Traditionally, I think we would appreciate that prehabilitation has generally been looked at in the surgical literature, where anesthesia and surgeons have generally been the physician supporting cast for this particular field. Nursing certainly has become a part of that, in addition to the prehab team that I've mentioned before. But from the medical side, this has traditionally been the case. But as we start to investigate the role of prehabilitation in non-surgical therapies for cancer, whether neoadjuvant or adjuvant, we do need to consult with our radiation oncologist colleagues, our medical oncologist colleagues, geriatricians, internal medicine, etc., and having a very well supported team of physicians that know the be-all and end-all of cancer treatment across the spectrum is quite important when we have complex care. We've been talking a little bit about this idea of multiphasic prehabilitation, acknowledging that many of the patients who undergo surgery probably have undergone neoadjuvant cancer therapy as well. And multiphasic in this particular scenario refers to a few different windows of opportunity. Perhaps prehabilitating them prior to the neoadjuvant or throughout the neoadjuvant therapy. But very often there's a gap of time after neoadjuvant chemotherapy and surgery where the prehabilitation focus may change. Perhaps during neoadjuvant chemo, we're focusing on cardiovascular conditioning to attenuate or prevent cardiotoxicity. Perhaps that's the focus, and perhaps we have a particular clinician for that. But in preparation for surgery, maybe there are surgical considerations that we have to integrate other colleagues from our team to make sure that we're optimizing other elements of their health. And it's not necessarily always a consistent group doing the same things over a long period of time. We've seen in some of the work that we've done that this can be a 6-month process that requires a lot of different people to work together. So we like to think of it not necessarily as a challenge, but rather an opportunity to look at collaborative care across a long period. We'd also like to highlight that for many people, their first diagnosis is not their last diagnosis, and that prehabilitation, unfortunately for them, may have to start again for another round of treatment. We recognize that people may undergo primary surgery for resection of their tumor, but that at some point in time, if they have a relapse, they may undergo systemic therapy. How do we prehabilitate again under a different set of circumstances when tissues have been removed or tissues have changed and the patient is feeling quite different? So certainly, multimodal prehabilitation may occur after the primary diagnosis, but we should also consider it in the case of the recurrent or secondary cancer scenario. And in thinking about all the people who, in addition to those I previously mentioned, could help, there's probably a role for everybody on this particular list to support prehabilitation. Spiritual care, especially for palliative patients or for patients who are undergoing very risky surgery. Do we need to consider their emotional and spiritual well-being? Financial advising in terms of planning for mortality for themselves, perhaps also their family members in terms of planning for post-operative management of those finances. Patient education in terms of making the resources that you provide appropriately comprehensible. A patient navigator to help them figure out who they're talking to over the course of a prehabilitation regime and then afterwards. A translator is something that, at least in Toronto, that has a very, very multicultural community, has become particularly important because we can't just provide prehabilitation to those who speak the language that we're speaking. Volunteers and students and researchers can all be a part of the team. Thank you so much to those who are here who deliver a lot of prehabilitation to our patients back home. A health coach is a great idea, and I think I'll leave off with support for the caregiver. We think of prehabilitation certainly as an intervention that is dedicated to the patient, but as a caregiver, how fit do they have to be to start lifting a person out of bed? How fit do they have to be emotionally and mentally to managing the entire continuum of emotional responses that their loved one is going through? And I think that in some ways, maybe they should be involved. Maybe they should be involved both as a person to support what we're providing for the patient, but also involved from the standpoint of being supported. So we all talk about patient-centered care. We should keep the patient in mind. But the idea being is that patient-centered is not the be-all, end-all of it. They need to be engaged As well, we need to ask patients what they want in a prehab program, what would help them best succeed. And I think if you have patient-centered care and patient engagement in the development of your program, you'll have an engaged patient. They are their own health champions, and I'd like to propose that if they're on board with the team, the outcomes will be the best. I'll leave it there. Thank you.
It's Desiree Chappell here. Just a quick reminder, subscribe to Top Med Talk. We're a daily source of news and conversation focused on perioperative care. We can also be found on Twitter, Facebook, LinkedIn, Instagram, and we now have a free mailing list with special offers and additional goodies for subscribers. Go check us out at topmedtalk.com. That's www.topmedtalk.com.